This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
David Knight from Christchurch Hospital. David's worked in Christchurch Hospital for quite a few years, which presents many challenges, but he also, if you look at his bio, graduated and spent some time in Leeds and managed to get out of there with all his own teeth, which I suppose is also most of them, which is impressive in itself. He's also an examiner with the college and has an interest in education. He's going to talk to us about a concept that maybe even be a little bit controversial, that blood might be good for you eventually.
I was recently following up an ex-ICU patient on one of the surgical wards, and to me he looked exactly the same as he did the day before, had exactly the same haemoglobin, but today, under the jurisdiction of the surgeons, he was receiving a unit of blood. The ICU reg I was with was livid. She couldn't believe the surgeons were still giving this outdated treatment with no proven benefit, when all the observational studies tell us it's really harmful. The surgeon felt pretty different. He said that in his opinion, anemic, frail patients always mobilise better after a unit of blood, and that's why he gives it. So who was right? This might be deeply offensive to any Canadians in the audience, so I apologise in advance. But if we're going to talk about transfusion, we need to at least think about the TRIC trial. But let's turn it on its head and look at the TRIC trial through the eyes of a transfusion cynic. In the TRIC trial, you could only get in the TRIC trial if you really had no chance of benefiting from a transfusion. So if you were grossly anemic, had an unstable haemoglobin, or if you had significant ischemic heart disease, it was likely that your clinician didn't have equipoise and wouldn't put you in the trial. They then randomised 100% of people to receive really, really toxic blood. And the other arm of the trial, you only receive blood if your haemoglobin dropped below 70, which is a level at which surrogate and observational badness seems to occur. And they found no difference in ICU, 30-day or 60-day mortality. But as the slide shows here, it's quite an old study. But there were some worrying trends in there as well, with relatively well people looking to do a little bit worse than sick people. Blood's got very much safer over the next 20 years. That's roughly how long it is since the first patients have been enrolled in the TRIC trial. The pool of donors has got narrower. Dirty Poms can't donate blood in Australia and New Zealand anymore because of our burger eating habits a few years ago. Each unit of blood has 99.995% less white cells than it did 20 years ago. At worst, it's an expensive way of doing nothing, and at best, it affects the immunomodulatory impact of that unit of blood. But probably most importantly is the administration around a unit of blood. It's now very unlikely that the wrong unit is going to get to the wrong patient. So it's estimated now that your chance of dying as a direct result of receiving a unit of blood is 1 in 350,000. Playing table tennis, 1 in 250,000. Does that make blood safe? Well, it's difficult to tease out such a rare event on a per-patient basis, so we need to look at populations, look at studies. So what you do is you give all your studies to a group of intelligent Danish people and tell them to do a forest plot and publish in the BMJ. And this is what they do. And as you can see, the diamond at the bottom crosses the midline. Crosses the midline that demonstrates there doesn't appear to be a difference in mortality between liberal and restrictive transfusion. Now, even though this was published in 2015, there have been a number of other studies published after this. And if you do this calculation today, the absolute risk reduction of liberal versus restrictive transfusion with respect to death is exactly the same as the absolute risk reduction of saline versus albumin in the SAFE trial, but with a slightly narrower confidence interval. So does that mean blood's safe? Well, I don't know if it makes it safe, but it suggests to me there probably isn't a massive signal from blood in the heterogeneous population that makes up our ICU population. There may be some people, and this is the classic example, where blood is extremely beneficial, and there may be some groups where blood is extremely harmful. So where might it be helpful? Well, some of us have anaesthetic half-sisters, and they work in perioperative medicine, as do some of us. And it's this group which in the last year there have been a number of trials that demonstrate a survival advantage to liberal transfusion. As I'm not a statistician, But the bottom line here looks to me just wheezing across the line of statistical significance, and opposite to how many of us would have anticipated this is going to go. So what do we do now? I'm confused. I'm always confused. I think what we need to do is look for TMOs. Now, TMOs are not people that are going to be helping Nigel Owens tomorrow. TMOs are patients with transfusion modifiable outcomes, patients that will actually do better if you give them a unit of blood. Now, the bad news is I don't know which patients are going to do better after receiving a unit of blood, but it's likely to come from a group of anemic patients, patients that are bleeding, and patients with coronary artery disease, ABC. So let's talk about anemia. Anemia is absolute or relative. The patient we talked about at the start had a hemoglobin that went from 74 to 73 to 74 to 72 to 69. He has adapted to that situation. He's had both cellular and tissue adaptation to that period of anemia. His 80-year-old father, whose hemoglobin had dropped by 40% down to 80 within 24 hours, has not had the opportunity for those adaptive mechanisms to occur and is much more likely to be at risk. If you look at liberal versus restrictive transfusion studies, they're not all the same. Some restrictive transfusion studies have a transfusion trigger at 10, which doesn't seem particularly restrictive to me. The largest study looking at patients with significant ischemic heart disease was a study called the FOCUS study in the New England Journal, and they had a transfusion trigger at 80. And there are probably a group of patients in that grey zone between 70 and 80 when it isn't safe to drop below that arbitrary number. But it's not a hard and fast. Hemoglobin in isolation is not a useful thing in isolation to look at. What about bleeding? Well, maybe it's the bleeding patients that our surgeons are generating in perioperative medicine, and that's why we're seeing the benefit in perioperative medicine with blood transfusion. If you're relying on an isolated hemoglobin when there's blood dipping through your toes when you're standing next to a patient, then you're not doing your patient a great service. So hemoglobin under those circumstances is not ideal. As many of you will be aware, there has been a study of liberal versus restrictive transfusion in patients with upper GI bleeds. In that group, there were significant more hemorrhagic deaths in the liberal transfusion arm, which may be a cause of the liberal transfusion, but they may not have been perfectly matched at baseline. You're sailing pretty close to the wind if you've got a hemorrhaging patient and you're waiting for your hemoglobin to drop to 69 before you transfuse that patient. Finally, coronary artery disease. If you've got a patient who's sitting there who didn't have any chest pain, who now has chest pain at a hemoglobin of 81, then that patient may very well benefit from a transfusion. There have been a couple of studies. There's been a study looking at patients who have had recent percutaneous cardiac intervention. Patients have an acute coronary syndrome, both of which seem to benefit from a liberal transfusion arm. So I don't know who's going to benefit, but we can look individually for those patients who might benefit from a transfusion. So in summary, the risk of transfusion has probably been overstated in observational studies. The risk is probably relatively small for the heterogeneous intensive care group of patients. That doesn't mean that you should be going out there and doing what I used to do in Leeds and transfuse everybody until their hemoglobin reached 100. The evidence does not necessarily support the choosing wisely question that came round to you all very recently about sticking strictly to a hemoglobin of 70 and not considering any of the other wider issues associated with that patient. And finally, I really think we need to consider individually, contextualise why that patient might need a transfusion. What's been the trend of their anemia? What's their absolute anemia? Are they bleeding? Do they have coronary artery disease before we subject them to a treatment that they may not need? Thank you.